So this morning we looked at 4 specific drugs that have been looked at that have a role for primary care practice. The first drug was Vorapaxar to prevent secondary cardiovascular events. We looked at canagliflozin for the treatment of type 2 diabetes, at suvorexant for sleep, and then finally rivaroxaban to treat DVT and pulmonary embolus. So Vorapaxar is a novel antiplatelet agent that works by a different mechanism than other antiplatelet agents. And the goal was to use this in addition to aspirin and other secondary prevention strategies to prevent second cardiovascular events in patients who've already had a previous event. So this is new. This was in a brand new class. It's the first in a new class working by a different mechanism to inhibit platelet aggregation by blocking the effect of thrombin when it binds to platelets and causing platelet aggregation. It blocks the binding of thrombin to platelets. So probably this wouldn't replace existing therapy. The question would be when it's added onto aspirin, what does it add compared with existing therapy? And currently in patients who require dual antiplatelet agent, the more commonly used one is clopidogrel, which has been around for some time. And the question really that I raised with the audience this morning is whether this new drug might take the place of clopidogrel as add-on to aspirin to prevent secondary events. So it turns out the benefit of this drug is relatively modest. The degree to which it reduces secondary cardiovascular events is quite small, in the range of 1 or 2% for absolute risk reduction. It also increases bleeding when added to aspirin compared to aspirin alone. And for that reason, the FDA actually terminated one of the trials of this drug early because of concern about bleeding complications. It is. It's, of course, the most important complication we'd be thinking about, and, of course, in using an antiplatelet agent, which is a type of an anticoagulant. So bleeding was one of the most important safety endpoints that they looked at. In a second study, which was more relevant for primary care, which was looking at this in secondary prevention for patients with pre-existing cardiovascular disease, the degree of increased bleeding was also seen in that trial, though this is the one that showed a modest benefit as well. So the FDA approved it even though the risks and benefits are fairly closely matched. I would say that since we don't know for certain or have no evidence that it's superior to clopidogrel, that in most instances where we need dual antiplatelet therapy, that clopidogrel would still be preferred compared with the new drug Vorapaxar. Vorapaxar has also not been studied, for example, in patients with coronary stents, which is another scenario where dual antiplatelet therapy is used and should not be used in that scenario. In fact, the FDA only approved it for use in patients with prior MI or peripheral artery disease, but decided to make it contraindicated if there was a prior history of stroke because of the increased risk of intracranial bleeding, actually, which was quite significant.